Hi everyone, my name is Rose and I'm a fourth year from University of Vermont. I've been at the VA for the past 2 weeks and I'll be visiting here for this week. This morning I'll be doing my presentation on prostate sparing. So what does a traditional radical cystectomy entail? In males, it usually means the removal of the prostate, seminal vesicles, and urinary bladder, which can cause nerve damage leading to erectile dysfunction. The reason why only the bladder isn't removed is because occult TCC and prostate cancer is prevalent in the prostate of these men. There was a report that showed in men undergoing radical cystectomy, the incidence of occult prostatic involvement with TCC was 20 to 48. Organ-sparing cystectomy is prostate or seminal vesicle-sparing cystectomy, which is further distinguished into apical, or the apex of the prostate, or posterior, or the posterior prostate and seminal vesicle sparing. The image on the left shows an apical sparing technique. For the image on the right, the red line is a standard radical cystectomy where the surgical plane is developed over the rectum and the vascular pedicles are sectioned in proximity to the anterior rectal wall. The blue line is nerve-sparing cystectomy, and the same surgical plane is developed, but the vascular pedicles are sectioned in proximity to the bladder wall, seminal vesicles, and the prostate to reduce damage to the neurovascular bundles. The green line represents potency sparing, where the surgical plane is now anterior to the seminal vesicles and is developed all the way down to the ejaculatory ducts. This helps keep the pelvic plexus behind the seminal vesicles untouched. The goal of this is to preserve the neurovascular bundles and distal sphincter complex. Leaving the posterior prostatic capsule and the seminal vesicles intact preserves the cavernosal neurovascular bundles and decreases the risk of erectile dysfunction. 75 to 80% of those receiving radical cystectomies can experience erectile dysfunction. Leaving the distal sphincter complex intact preserves external striated sphincter complex and improves continence rates. 5 to 18% have daytime incontinence and 13 to 27% have nighttime incontinence. These are the 3 studies with the largest N number looking at local and distal recurrence in prostate-sparing cystectomy. I want to particularly focus on the percent of pathologic stage T2 or less and local and distal recurrence. In the study by Mertens and Rosette, their local and distal recurrence is very similar to each other, and you can see how much the distal recurrence increases. What's interesting is, in the study by Muto, there is a decrease in recurrence, especially the distal portion. It is hypothesized that the reason for the results lie in the percent of pathologic stage T2 or less. Their study predominantly only included men with T2 or less compared to the other 2 studies. Looking at occult prostate cancer, there was a paper who looked at 121 whole mount prostates from radical cystoprostectomy specimen with the mean age of 67 years old. They saw that 48% of incidentally detected prostatic adenocarcinoma were clinically significant, which they defined as Gleason 7 or greater, tumor volume greater than 0.5 milliliters, or the presence of extraprostatic extension, seminal vesicle involvement, lymph node positivity, or positive surgical margin. 79% of clinically significant cancer was located in the apex, but only 25% of all detected cancer was in the apex, which suggests that most prostate cancer is located elsewhere. This is another paper that looked at occult prostate cancer in 204 men, mean age being 67 years old. They had slightly different results where only 28% had incidentally found prostate cancer, 20% had Gleason 7 or greater, and 12% was in the apex. They did find that all men with apical involvement had concurrent multifocal involvement in the proximal part of the prostate, suggesting that this technique isn't oncological. In terms for screening, they do a 12-core biopsy in those with an abnormal DRE or PSA. The use of multiparametric MRI and transfusion prostate biopsy has not yet been studied in the prostate-sparing cystectomy literature, so it'll be interesting to see if it ends up helping with better patient. Treated occult prostate cancer won't impact survival as much as residual or recurrent urothelial carcinoma. This paper looked at 235 whole mount cystoprostectomy specimens, mean age is 68. They found that the incidence of prostatic urothelial carcinoma is 33%, and that pre-op CIS and bladder, neck, and trigone involvement was significantly associated with the presence of prostatic urothelial. Another study looked at 246 men who underwent transurethral loop biopsies of prostatic urethra and found that the biopsies missed 19% of patients who had prostatic urothelial carcinoma. They concluded that screening should not be solely based on this biopsy, but should also include the absence of CIS and trigone and/or bladder neck tumor. This is a rough summary of the patient selection criteria. CT2 or less is based off on the 3 studies I previously talked about. There isn't a set defined age cutoff, but it's generally agreed upon that increased age means an increased risk of incidentally found prostate cancer. Good performance status and good pre-op sexual incontinence function is important to establish, since that is the main reason why this technique is even considered. The rest is ensuring that your patient doesn't have prostate cancer. Prostate-sparing fares to radical cystectomy. The study looked at 63 men who had prostate-sparing cystectomy and did a historical control of men matched by clinical pathologic characteristics. There was no significant differences with the local and distal recurrence. On your left, you see a Kaplan-Meier curve demonstrating that there was also no difference with the 5-year disease-specific survival. This other paper looked at the same issue, but they did a randomized controlled study of 40 men with CT2 or less receiving prostate-sparing or nerve-sparing radical cystoprostatectomy. For prostate-sparing, the rate of occult prostate cancer was 15%, prostatic urothelial carcinoma was 10%. For nerve-sparing, the rate of occult prostate cancer was 40%, and prostatic urothelial carcinoma was 20%. These graphs here show recurrence-free, metastasis-free, and survival probability curves, and at 12 months follow-up, there were pretty much no significant differences in any of these. Besides looking at oncologic outcomes, it's important to see how the functional outcomes differ as well. In those who had prostate-sparing cystectomy, 50 to 100% have daytime continence, which is comparable to the standard. 31 to 100% have nighttime continence, which is slightly higher than the standard. The reason why we see such a wide variability in the results is because when looking at all the different studies, there wasn't a single standardized questionnaire that people used to objectively evaluate the urinary function. Sexual function, 68 to 100% had normal erectile function, which is comparable to the nerve-sparing radical cystectomies. In summary, organ-sparing cystectomy is controversial because there is an increased risk of worse recurrence rates. There doesn't seem to be much of an improvement in continence, and there have been such variable results among the different studies. People are still debating if this is feasible. Those in favor argue that some studies have suggested similar oncological outcomes, or there needs to be a standardized objective functional measurement to more accurately assess this issue, or that surgical techniques are getting more sophisticated. I wanted to briefly say thank you for having me here at Stanford. I've had a great time at the VA, and I'm excited to see how the main hospital is like this week. So thank you very much again.